Do doctors ever consider weaning patients off preventatives as an option? Is monophasic or multiphasic a factor? And how long would someone need to be relapse-free for it to even be a consideration?
So I think this is a million-dollar question, so to speak. So with monophasic, processes, I think that there's a lot more flexibility. We typically treat the acute attack, and then we're in a phase of monitoring, especially in pediatrics, as most of our patients will not have another attack. When we get into that relapsing group, I think that that becomes a larger problem. So certainly if a patient becomes seronegative, meaning that they lose their antibody over time, I think that gives us a lot of confidence about coming off therapy. But I don't know if there's necessarily one time frame that is uniform for all patients. We try to get into that 1 to 2 year window before we're coming down on therapy. And ideally, even though we don't have great titer bases to go off, we want to use the other clinical features. So is the OCT data stable, so the optical coherence tomography? Is the MRI stable? And obviously, is the patient not relapsing during that? So if all of these clinical pieces are fitting in to show stability, I think that that gives us better positive predictive value of a patient doing well off therapy. But thus far, we've still had a few that we try to come down and we deal with a relapse, which is unfortunate.
Yeah, no, I agree completely with everything that Dr. Santoro said. Just to add a couple of points that I try to employ in practice is, so I generally, again, for monophasic disease, generally the treatment is geared towards the relapse. Preventative therapy, I generally institute only for patients who have shown that they have relapsing disease. In patients with relapsing disease, I think there are a number of considerations in order to decide to wean the therapy. And it's always a discussion with the patient, of course, and I think to some extent an important feature is also the amount of disability that may have been accumulated from prior attacks. So if somebody has recovered very well from prior attacks and has been stable on a therapy for a number of years, I think that there is a potential rationale to wean, provided that the patient is comfortable with that, because then there is the likelihood that if another attack occurs, the prior history supports that perhaps the recovery will be good again. Another feature also that's quite important to bear in mind is also the side effects from these treatments. So if a patient is experiencing things like recurrent infections due to being on an immunosuppressive drug, or if they are intending to become pregnant, which is another thing that happens quite a bit since this is a disease that affects young adults, and so childbearing is another important consideration when we're deciding to continue these therapies. All of these features really need to be taken into account, and it's an individualized decision for which I think we need a lot more data to help guide us for what the risk of relapse is in people when we're taking them off treatment to help guide us in this therapeutic decision making.
We're very highly cognizant of that in pediatrics because of the growing body, growing brain concept as well. So especially with our immunosuppressive or steroid-sparing medications, we want to make that, thread the needle between the balance of immune suppression and prevention of attacks, but also making sure that the body has the best chance to grow and develop as it should.